Neuroendocrine tumors (NETs) are a diverse group of cancers that arise from neuroendocrine cells, which are found throughout the body and have traits of both nerve cells and hormone-producing cells. These tumors can occur in many organs but are most commonly found in the gastrointestinal tract, stomach, intestines, pancreas, and lungs. Some neuroendocrine tumors are slow-growing indolent while others can be aggressive and fast-growing. Key characteristics of neuroendocrine tumors: NETs. Hormone production. Some NETs produce excess hormones, causing specific symptoms related to hormone overproduction called functional NETs, while others do not. Non-functional NETs. Diverse locations. NETs can occur in various organs, including the lungs, pancreas, stomach, intestines, and thyroid. Medullary thyroid carcinoma. Variable behavior. NETs can range from benign non-cancerous to malignant cancerous and may grow at different rates. Types of neuroendocrine tumors. NETs are classified based on their location, as well as their ability to secrete hormones. Major types include gastroenteropancreatic neuroendocrine tumors (GEP NETs), carcinoid tumors, often found in the gastrointestinal GI tract, particularly in the small intestine, appendix, and rectum. These tumors are typically slow-growing. Pancreatic neuroendocrine tumors (PANCs) NETs that develop in the pancreas. Examples include insulinomas, which produce insulin, and gastrinomas, which produce gastrin, leading to excess stomach acid. Pulmonary neuroendocrine tumors found in the lungs. Pulmonary NETs include small cell lung cancer (SCLC), which is an aggressive form of NET, and typical and atypical carcinoid tumors that grow more slowly. Medullary thyroid cancer, the type of neuroendocrine tumor that arises from the parafollicular cells (C cells) of the thyroid, which produce calcitonin, the hormone that helps regulate calcium levels. Pheochromocytomas and paragangliomas, tumors arising from adrenal gland cells or similar cells located near blood vessels and nerves. These tumors can produce adrenaline and noradrenaline, leading to high blood pressure, headaches, and sweating. Merkel cell carcinoma, the rare and aggressive neuroendocrine tumor that develops in the skin and is associated with a virus Merkel cell polyomavirus. Symptoms of neuroendocrine tumors. The symptoms of NETs vary depending on the location, type, and whether the tumor is functional, producing hormones, or non-functional. Functional NETs. Hormone-secreting tumors. Carcinoid syndrome occurs when carcinoid tumors secrete excess serotonin. Symptoms include flushing, redness of the face and neck, diarrhea, wheezing or shortness of breath, heart palpitations and heart valve problems. Carcinoid heart disease. Pancreatic NETs. Insulinoma produces excess insulin, leading to low blood sugar, hypoglycemia, causing sweating, confusion, and fainting. Gastrinoma produces excess gastrin, leading to Zollinger-Ellison syndrome, with symptoms like severe stomach ulcers, abdominal pain, and diarrhea. Glucagonoma produces excess glucagon, leading to diabetes-like symptoms, weight loss, and a skin rash called necrolytic migratory erythema. Pheochromocytoma/paraganglioma. These tumors produce excess adrenaline or noradrenaline, causing episodes of high blood pressure, headaches, sweating, and palpitations. Non-functional NETs. These tumors may not produce hormones, so they often grow silently until they cause symptoms due to their size or location. Abdominal pain or discomfort, bloating, obstruction in the intestines, unexplained weight loss, persistent cough or breathing problems if in the lungs. Diagnosis of neuroendocrine tumors. Diagnosing NETs can be challenging because their symptoms often mimic other conditions. The diagnostic process includes blood and urine tests. Functional NETs can cause elevated hormone levels, such as serotonin, chromogranin ACGA, or specific substances related to the tumor. 5-HIAA. The breakdown product of serotonin is measured in the urine to diagnose carcinoid syndrome. Imaging tests. CT scan or MRI, helps identify the location and size of the tumor. Octreotides can somatostatin receptor scintigraphy uses a radioactive substance to bind to somatostatin receptors on the surface of NET cells. Gallium-68 PET/CT scan, the more sensitive imaging technique for detecting NETs. Biopsy. The sample of the tumor is taken and examined under a microscope to confirm the diagnosis and determine how aggressive the tumor is. Endoscopic procedures. If the tumor is located in the GI tract, an endoscopy or colonoscopy may be performed to directly visualize the tumor. Staging and grading NETs are classified by grade and stage to help determine the best treatment approach. Grade refers to how fast the tumor cells are dividing. Low grade G1 slow growing. Intermediate grade G2 moderate growth rate. High grade G3 fast growing, often more aggressive. Stage refers to the extent of the tumor's spread. Localized, confined to the area where it started. Regional, spread to nearby tissues or lymph nodes. Metastatic, spread to distant parts of the body, such as the liver, bones, or lungs. Treatment options for neuroendocrine tumors. Treatment depends on the type, location, stage, and grade of the tumor, as well as the patient's overall health. Common treatment approaches include surgery. Surgery is the primary treatment for localized NETs and involves removing the tumor and any affected tissues. In cases of metastasis, especially to the liver, surgery may still be an option to remove or reduce tumor burden. Medications. Somatostatin analogs, e.g., octreotide or lanreotide. These drugs help control symptoms of hormone-secreting NETs and may slow tumor growth. Targeted therapy. Drugs like sunitinib and everolimus use target-specific pathways that promote NET growth and can be used for advanced or metastatic NETs. Peptide receptor radionuclide therapy (PRRT). This treatment uses a radioactive substance attached to a somatostatin analog to deliver radiation directly to NET cells. Lutathera is an example of PRRT for NETs. Chemotherapy. Chemotherapy is often used for high-grade or aggressive NETs, particularly small cell lung cancer and some fast-growing pancreatic NETs. Common drugs include temozolomide, capecitabine, and platinum-based therapies. Radiation therapy. Radiation can be used to shrink tumors that are causing pain or symptoms, particularly in metastatic or inoperable cases. Liver-directed therapies. If the tumor has spread to the liver, radiofrequency ablation destroying the tumor with heat embolization blocking blood flow to the tumor, or liver resection surgical removal of part of the liver may be used. Prognosis. The prognosis for neuroendocrine tumors varies widely depending on the tumor's grade, stage, location, and functionality. Low-grade, localized NETs often have a good prognosis, with high survival rates if detected early and treated appropriately. High-grade or metastatic NETs have a poorer prognosis, but new treatments like PRRT and targeted therapies have improved survival rates. Some NETs, especially low-grade ones, may remain stable for years or even decades with proper treatment, allowing patients to live relatively normal lives. However, aggressive, high-grade NETs can be more difficult to treat and are associated with shorter survival times. Conclusion. Neuroendocrine tumors are a complex and diverse group of cancers that can range from slow-growing to highly aggressive. Early diagnosis is key to improving outcomes, and the treatment approach is often tailored to the specific characteristics of the tumor. With advances in targeted therapies, immunotherapy, and specialized treatments like PRRT, the outlook for patients with NETs continues to improve.